Yeah, and now, yeah.
Okay.
Longish tail.
So can you please put all the participants, other participants on mute? So all the Zoom users, please rename yourself, or else you'll be forced to remove you from the list. So Zoom users and phone users, please rename yourself. So I'm starting. So good evening, one and all. As we proudly celebrate the National Family Medicine Day today on September 27th, 2023, because it is this day is chosen because Academy of Family Physicians of India (AFPI) was became a reality in 2010 September 27th. So on behalf of the Spice Route India movement, we would like to express our gratitude to all the pioneers and the senior members who have immensely contributed to the specialty of family medicine in yesteryears and have paved the path for the future generation for a better takeoff. So, what next after your post graduation in family medicine? And this was a question within quotes for every resident who is passing out each year. So, that is the reason why Spice Route decided to throw some light on this fact to enlighten our postgraduates through our webinar. What are the career opportunities after a training in family medicine? Myself, Dr. Vishnu, I've completed my DNB Family Medicine from KIMSL Trivandrum, currently the Academy Coordinator of KIMSL and National PG Coordinator for Spice Route. Today with us, we have 8 eminent panelists who have excelled in different sectors of their practice to share their experiences. So to the speakers, I would remind that each speaker will be having 6 minutes to speak, and we will have a question and answer discussion. So first of all, many of us, after the sector, what are opportunities and roadblocks for a young family medicine resident who have just completed the training, who wants to practice in a government sector? To speak on this, we have Dr. Serin Kuriakous. Dr. Serin Kuriakous have held pivotal roles in various organizations of family medicine and Secretary of Spice Route South Asia region. He was also the Epidemic Intelligence Service Officer at National Center for Disease Control, New Delhi, and is also serving government health services. He was the past secretary of AFPI Kerala chapter and currently the advisory member of AFPI Kerala chapter. Over to Dr. Serin Kuriakous. Sir, please share your thoughts.
Good evening, all, and thank Dr. Vishnu for the wonderful introduction. So, and I will try to stick to my time. Uh, all of you may know that there are no specialist post in most of the state government health services as of now, except there are some exceptions like UP and all, where you will get a post as a specialist family physician or a specialist physician where you can practice. with your postgraduate degree. But at the same time, if you are working in any state government, especially in Kerala or any other state where the basic qualification is actually the MBBS only, but we know that there are many postgraduates who get into this health system even after their post graduation. The point is, if you are posted in a primary health center or a family health center or a community health center, you will be able to exercise all your skills that you have learned during your 2-year or 3-year course, during your MD or DNB or diploma. So the benefit is one thing. Like any other government job, you will have a good stability. Job stability is there. You will get good number of leaves and all other benefits along with that, and you have a routine work hours. And if you are not in charge, you don't have to worry about any administrative work and all. And apart from this, when people realize that you are competent enough, or you are a specialist family physician, people means, or the administrators will assign you with specialized task. We know that this happened during COVID times, and we were equally treated as any other specialist during that pandemic time. And once you get to establish your name in your working institution, you will get a good name, good fame, and people will start coming to you seeking for your specialist care. Now the point is, even if you see 10 patients, or even if you see 100 patients, your salary in the government sector is going to be the same. But at the same time, most specialists in the government sector, what they do is they establish their own clinic. So once you are into government sector, and once you have established your fame, you can have a good number of patients. So this is actually midway between private and government. So with the help of this permanent post in your government sector, you will have a permanent and fixed income and a lifelong income, and you don't have to worry about your job stability and all. And at the same time, once you start your own practice, so you are more into a private thing also, so you can fix your own consultation charges, and you can get as many number of patients as you want as you advance through your career. So if you are interested into government sector, this is the best option I would suggest. You can start with your practice and build your patient base in the locality where you work, and gradually set up a private clinic. And one more opportunity is there. If you are into administrative side or public health, with this background, you will be able to do that as well. I'm ready to take questions at the end of this session. Thank you.
So thank you, Dr. Sarin, for highlighting what are the opportunities, the clinical as well as the administrative part, as well as when you're working in a government setup, you can. Family medicine practitioners always do wonders through their self-practice. That too in various sectors. We have practitioners in an urban sector, rural sector, as well as in the corporate sector. First, I would like to invite Dr. Gunjan to discuss about how is your family practice in family medicine practice in an urban sector. Dr. Gunjan, she completed her DNB family medicine and is a consultant family physician at Max Hospital, Vaishali, and the director and consultant family physician at Pursuit of Health Clinic, Ghaziabad. She's also the National Treasurer and FM360 Coordinator of Spice Route India Movement and Young Doctor Lead of Wonka Working Party of Women and Family Medicine. Over to Dr. Gunjan.
Thank you, sir. So, hello everybody. Today we'll be discussing a lot of career opportunities. And while doing that, there is one important thing which I have felt a lot of PG students want to know. What will they do after they have passed their degree? Now, job security in terms of getting into a college as faculty or any job which government is putting up for you is a lot of dependency. Once you take a clinical branch, your first priority is you want to see patients all your life. And if you are generating your own setup, you're not dependent on anybody. You never have to wait what kind of job offers are there, is there saturation or not, your branch is at par with other branch or not. So you have to come out of that loop, create your own space. When we are talking about private practice, you have to understand the diaspora, the population is different in different parts of the country. The rural population and urban population has different kind of demands. When we start our practice in an urban setup, we have different kind of challenges. Primarily because the tertiary care center has a lot of facilities and of course, super specializations. So one thing I felt my juniors have put up that will they stand a chance when they set up a practice in an urban center? So understand one thing, the challenges start changing depending upon what is available. A lot of patients feel when they go to a corporate hospital, they don't know which department they have to talk to because there are so many departments. For a simple pain in the back or headache, they have to go to a physician or an orthopedician or a neurologist and whatnot. They get multiple scans done and they're utterly confused at the end of the day. And this is where a family physician gets in. You are the first contact point where the patient can talk to you about his problem, wholesome problems, and you provide them the right direction of where they have to. So when you set up a practice in an urban area, you become the choice of patients. The whole family comes to you, from a newborn to the elderly, everybody can discuss all their issues. So there you have a golden chance. Another thing, trying to set up in an urban area, the cost factor is a huge thing because of course the setup will need more money. So how do you approach this? When you come out of your degree, the first job you get is a senior residency, which will definitely have flexible working hours. And in a practice, you should provide fixed working hours in your setup because the patient should know that at this time the doctor is available, which of course is challenging if you have shift duties in your hospital. So one thing you can do, go complete your senior residency of 3 years, thereafter get a junior consultant job and then start 2-3 hours practice in the evening, or leave your job completely and start a setup, which is again challenging because a lot of students need financial security in the early years after crossing their PG degree. So your approach depends upon how financially secure you are. Don't worry about this, that you need more experience before starting your practice. Whenever you start is the 0 year. Whatever you have learned throughout your MBBS, internship and PG degree is going to be helpful. And the learning has to go on throughout your life. It's not just 3 years of PG residence. So once you start, you give time to your patients and you bring in consistency and dedication. That's how you start your work. May it be rural area or urban area, this is something which has to be there in your practice. And once you start doing this, after a few years, you realize that your dedication pays off because the patients want somebody who listens to them and appreciates their attention. Okay? And any other things you want to ask, you will need to put up in the message or bring it at the end of the session.
Thank you, Dr. Gunjan. And Dr. Gunjan is practicing in Ghaziabad after her post-graduation. I think she's passed out
I
in
started
2020.
immediately. Yes, 1 year after
After-
senior residency, I did that.
Yeah. So it is a good advice that you have got from a recent pass out and a decent practitioner, I should say. So thank you, Dr. Gunjan. And yes, rural sector is another area where it is a challenging area where family medicine people are flourishing. And to discuss in detail about how a family sector, I would like to invite Dr. Jayajit. Dr. Jayajit Guha is a DNB family medicine postgraduate from, he completed his post-graduation from Gangaram Hospital, Delhi, And he has worked at rural sector in Uttarakhand state for 3 years. And he's working actively in the initiative Swasth Himalaya Abhiyan, serving in the remote villages in Uttarakhand and doing training for local village volunteers to facilitate better health environment. Dr. Jayajit, over to you.
Dr. Jayajit, you're on mute.
Good evening, everyone. Am I audible?
Yes, yes.
Thank you for this opportunity. So, we know that more than 70% of population of our country lives in the villages. So, it is believed, many of our doctors believe that it is difficult to practice in the rural areas. But I will say that although it is difficult, it has different challenges compared to the urban areas. But it is very rewarding, and financially also you can earn if you look into the basic needs of the community, what the community needs at that area. So when we start a practice in a rural area, it could be of three types. It could be either purely rural practice that we set up, you have to set up your center in a purely rural area. Second is that you set up your main clinic in a small town near the village area, and then you can do twice a week visits or once a week visits to the nearby rural area. Or the third way in which you can practice is through some voluntary NGOs. So whichever way you start the practice, first I will say that you take 6 months to analyze what are the felt needs of the community in that area, because urban, this is the difference which we have to do in a rural setup. Include local staff in your local population in your hospitals, in your clinic staff. Then interact with the local government authorities, the health authorities, interact with the local sub-centers and primary health centers, the doctors and the ANMs who are practicing in that area. Analyze what is the health-seeking behavior of the community in that area, whether they are going to the local practitioners, the unqualified practitioners, or some practitioner who is far away from that area, or they are going to the nearby small towns. What are who are the different practitioners available, and who are the specialties available in that area? Then what are the nearby labs available to you? What are the nearby pharmacies available to you? So these things we have to, whenever in any rural setup, we have to see, because facilities are always less in a rural area, and we have to take the initiative because we want to set up our own clinic. So after a period of 6 months, you will get to know that what does the population in that area need, and accordingly you can further continue your practice.
Vishnu, you're on mute.
Thank you, Dr. Jayajit, for sharing your experience that you have earned by practicing in the rural sectors in Uttarakhand over the last 3 years. And now I would like to call upon Dr. Jyotika, who is a family medicine specialist practicing in the urban corporate sector of Bangalore. Dr. Jyotika completed her DNB Family Medicine and MRCGP International, and she's a consultant family physician and clinical lead in RxDX Samanvay Bangalore and executive member of AFPI Karnataka chapter and national secretary of Spice Route India movement. Over to Dr. Jyotika.
Thank you, Vishnu. Good evening, everyone, and happy National Family Medicine Day to all of us. I think it's great to see this participation today. Makes us happy that we chose the right topic for the right day. And it also means that you all are looking up to us to help you all. So that means a lot. And a lot of senior faculty have also joined us today. Dr. Reshmi is here, Dr. Mohan is here, Dr. Suresh Kumar Bansal is here. We welcome all of you, sir and ma'am. So to describe my practice, so I practice at a corporate clinic. So this clinic is actually, I mean, it's actually a chain of primary care clinics, which was started by doctors, not by somebody who is a non-medico and who wanted to set up a business. Like Dr. Jayajit spoke, that first see the unmet needs of the community and then address those. So this was exactly that was done with this particular chain of clinics. And I think what I have seen is many cities, including Mumbai, Delhi, Pune, and a lot other places also have started this concept wherein they are now trying to give pre-hospital care. So the place where I practice, we have diagnostics, we have in the form of lab as well as radiology. We have all other specialty doctors coming as visiting consultants. And the physician is the backbone of this chain of clinics. So that way, we are able to serve the community in the best way possible. And at the same time, we are providing home care services, which is another very important strength of a family physician, which not everybody can do. An internal medicine physician or a surgeon or somebody else may or may not be able to do house visits. But it's, our specialty that we can do those home visits and give a comfort to the people at their homes. Along with that, at my center, of course, I think it's a unique feature. We also have a daycare room and a operation theater. So that way, we are able to provide to the patients an opportunity that they can undergo small surgeries or procedures as a daycare, and they don't really have to get admitted. So that again is the quality of a family medicine specialist. All of us would want a place where our patient can come, even if they require a small procedure, if they require an evaluation, they require a scan or a blood test, everything should be able to be provided. So there are a lot of such opportunities coming up in many cities of India. And I think that is a good opportunity which the PGs can look out, I mean, rather the ones who have passed out, you can definitely explore this opportunity, especially if we are not looking at setting up our own practice immediately for any reason. Either we don't want to or we cannot, whatever be the reason. We have these options coming up now. I think it's important also to be smart to look at these options. At the same time, I would want to advise people that family medicine specialist is a very good entrepreneur. The way you run your own practice, you can very well run these centers, and it is a good platform to showcase our talent in front of other specialists or other colleagues and the people who are ready to have such a setup. It is very good that they get a family physician to run the setup, because along with seeing your patients, giving them advice, giving them home visits, we also have the capability to be the administrator. We know how to, run the place. So that is a quality that we should recognize in ourselves and use this opportunity whenever it comes across to us. Don't feel that, only a so-called big name can run a place. No, we can use this opportunity and show the whole fraternity what we can do. So it's very important to look out for such, options. And one advice that I would want to give when we are working in such a setup, never ever forget to collaborate with your fellow specialists. So whether they are surgeons, whether they are gynecologists, pediatricians, or anybody, physiotherapists, we should always be collaborative. So an example that I want to give, a patient of mine underwent cholecystectomy, was operated at a nearby hospital. And after the surgery, the surgeon was very happy to let me follow up with the patient rather than the patient running around for dressings and for, post-op care in different ways. And the patient was a diabetic, so of course we needed to monitor the sugars. So that way, many other colleagues of ours are happy to see that their patient is well taken care of, and it doesn't, every responsibility does not fall on them. So we tend to practice in primary care, and at the same time, maybe like at least in my situation, I am not ready to set up my own center as of now. So this is a good balance for me. So this is about primary care in a corporate clinic. Actually, I just want to add one more experience of mine. Vishnu, can I take 1 minute?
Yeah, one more
Okay.
2020.
So before I joined this place, I was working in the health check department in a famous corporate hospital in Bangalore. So nowadays we have seen that many, or rather most of these corporates want to take family physicians to run their health check department. On one side, I think it is becoming cliche and it is becoming repetitive. But at the other time, I feel it's a good chance for us to step into tertiary care and show them our capability. Again, collaborate with those physicians, collaborate with other specialists like surgeons, uh, orthopedicians, neurosurgeons, whoever is there in that hospital. When we collaborate with them, they get a confidence. And many a times, people in India do not know that a family medicine specialist exists. But when they see us working with them, it makes all the difference. This I am completely telling from my own experience, from where I have worked previously. So I think it's important to be confident. It is important to be collaborative, open to options. And at the same time, we all are there for each other whenever we need any guidance, whether we need any suggestions. The forum is always available. So that's all from my side.
So thank you, Dr. Jyotika. And now that you have heard what are the opportunities in the government sector and what are the individual practice opportunities in the rural corporate sector as well as the urban sector. Now, just like what Dr. Jyotika just told, most of us would have done our training in family medicine from corporate hospitals or multi opportunities we have in that kind of setup. What are the opportunities available for a family medicine specialist? So to enlighten on the experience as a consultant in a corporate hospital, I would like to invite a close colleague of mine, Dr. Namita Unnikrishnan. She is a family medicine specialist at KIMS Health Trivandrum, who is entrusted with the responsibility of running family medicine clinic at the city centers of KIMS Health. And I would like to invite Namita to share the experience in a hospital-based practice. Over to Dr. Namita.
Thank you, Dr. Vishnu, for that wonderful introduction. Hi, good evening, all. So before I start, let me say a huge special thanks to the National Spice Route team for actually organizing this webinar. Because as soon as the NEET results are announced, I am actually flooded with quite a number of calls asking the same question, the career opportunities once we pass family medicine post-graduation. So, and I'm pretty sure that most of us will be handling similar calls in the similar scenarios. So, I work in a quaternary care hospital, which has 4 feeding centers or wellness clinics, like it is called here. And here at the main hospital, which is also an epitome of academic institution, we have 5 family medicine specialists and 12 residents. And here we have a family clinic which tends to the healthcare needs of the staff and their family. And we also have a vaccination clinic, which is specially dedicated to the adult vaccination. Here, even the public can avail the adult vaccination. This is run by a family medicine registrar. And here also, like Dr. Jyotika said, we tend to home care services where the family physician pays a visit to the homes of those in need, when and where we can deliver care as needed. And we also organize preventive healthcare screening camps, awareness camps, school health programs, etc. And a few of our family medicine registrars work in this in the Department of Internal Medicine as junior consultants, where they have this OP privilege but no inpatient privilege. And at the wellness clinic, like the one where I'm working, similar to Dr. Jyotika's, here we work as the first line of defense for non-urgent health concerns of the community, where I usually deal with chronic diseases like managing hypertension, diabetes, dyslipidemia, also the seasonal illnesses, and also for routine vaccination. And for all this, the community, the people in the community, they come to us as being the first line of defense. And here also, I undertake minor procedures like incision and drainage of abscesses, pairing of callosities, sebaceous cyst removal, etc. We also have the opportunity to deliver antenatal care and manage routine gynec cases like abnormal uterine bleeding, menopausal concerns, vaginal discharge, etc. And I'm very proud to say that I have patients from cradle to grave, and with whom we also develop a personal relation to. And our basic, one thing that we need to understand is we have the full freedom to work up patients, but we need to know at what point we need to refer to specialists. So this is an important crux point in our practice, where we can actually refer them to the specialist and we can follow them up. And the advantages of working in an institution like the hospital practice is we can be actively involved in academics, as well as we have a strong back support of various specialities like infectious disease department or the internist or the surgeons, etc. Another advantage is like we have a desirable work schedule like 9 to 5 with no night calls. But when we have a hospitalist, when we are posted in the Department of Internal Medicine as a registrar, we might have night calls also. And another thing that I want to tell the aspiring family physicians or the postgraduate students is that whatever that we learn during our MBBS, we can actually develop a broad knowledge on almost everything and still be in touch with all of that. And we are able to manage almost everything that walks over to us in our OP. And not to forget, regarding the salary, in such a setup, we are actually, dealt with salary at par with other specialties. Or we also have the, concept of eroding concept, where our salary will be decided upon based upon the number of patients and the number of diagnostics, etc., that we run. Another disadvantage of working in such a setup will be, we have a lot of documentation to do. And we might be forced to practice defensive medicine and not take a typical parental role in taking care of our patients. And that.
So thank you, Dr. Namita. Just like what she told, we have different sectors of opportunity in one block itself. That is, as the role of clinicians running in the hospital, staff clinic, doing the academic part, the chain of feeding center management, all these things can be incorporated in a corporate hospitals kind of setup in which we are practicing. So next, I would like to answer $1 million question. Rather, I would like to call upon a doctor who can answer that query. What are the super specialties that we family medicine people can do after the residency? A super specialty option is currently not available, but I would like to rephrase the questions. What more we can do after the family medicine residency to excel our clinical practice? To discuss on this perspective, I would like to invite Dr. Gauri. Dr. Gauri is a developmental physician associated with Aster CMI Hospital and a family physician at Canara Diagnostics Centre, Bangalore. She pursued MRCGP from RCGP UK and completed a fellowship in child development from Center for Disease Development and Disabilities, Bangalore, And Dr. Gauri's experiences in different specialties have empowered her to deliver a holistic treatment approach to her patients. So I would like to invite Dr. Gauri to share the experiences in the specialization areas that she have experienced. Over to Dr. Gauri.
Thank you, Dr. Vishnu, and thank you to SpiceRoute for giving this opportunity and wishing everybody a National Family Medicine Day. So just to start off with a little bit of background with my UK training in family medicine. In UK, the difference from here is mainly that you're mainly based in community. So community service, and you're seeing patients like previous speaker said, cradle to grave. You're the first port of call. You're seeing everybody. You're managing how much ever possible in a community. And again, I've been exposed to another category working there as well as a GP with special interest. I think that is where we come up into developing specialist interest, special areas of subspecialization rather than saying super specialization, depending upon where your interest is. And then once I've moved into India, the thing that has caught me, which has in the area in which I've always had an interest, is pediatrics. So there is a niche or thing, what you call a community pediatrics. So coming into community pediatrics, it's where you look into children with needs with chronic health conditions. So I had the opportunity to develop my specialization in developmental pediatrics as a private fellow with one of the leading child development pediatrician here in Bangalore. And I've been able to kind of develop this as a special interest as well. So now I have a dual role. So I work part-time as a family physician, working in a community in a diagnostic center where I do the regular family practice. I also work in a child development center with my skills in the child development. And coming from a family medicine background, I can say this has really helped me immensely in taking care of a family as a whole. So as we know, in chronic health conditions and diseases, it's not just dealing with the disease. It's a long term. The whole family needs to be on board. The psychological impact it has. So being a family physician, being able to deal as family as a unit here, uh, uh, this opportunity as a family physician and being in a pediatric setup with children with disabilities has given me an upper hand. And also, it doesn't stop here. The thing I would also like to highlight is being a family physician, you can open up your wings to whichever area you want. So it's not only in a clinic. I go into community, into schools where I can educate the children with the kind of things from health education to kind of whatever hazards we are facing these days, like screen time. So children I can educate, parents, teachers. So even community education related to pediatrics, pediatric health, I'm able to address and take care as well. So what I would like to say and conclude is that sky is the limit. So wherever you want to take it up, wherever you want to go forward, you can always take a step forward, be creative. So open up, there is no end or limit to opportunities. So I think I will conclude with that. Thank you, Vishnu.
Thank you, Dr. Gauri, for enlightening us on the prospects of specialization in pediatrics and the various child like opportunities in geriatrics, palliative care, So many areas are where we as a family physician can excel. So just moving on to the next, before moving on to the next speaker, I would just like to call upon our senior member of family medicine and the vice president of AFPI National, Dr. Mohan Kubendra sir, to just give a few words on your experience on your practice in family medicine. Over to Mohan sir.
Hello, good evening. Can you all hear me?
Yes, sir.
Okay. Firstly, thank you, SpiceRoute, for this opportunity. And at the outset, I would like to congratulate and wish all the AFPA members and in fact all the family medicine doctors on this very momentous occasion of the AFPA Foundation Day, and which is also observed as the National Family Medicine Day. And I'm very happy that this topic is rightly chosen for today's deliberation, because this is the question: what would I do after my post-graduation? This question looms in your mind while you're doing your post-graduation. This was the question which was going through our minds when we were doing post-graduation way back in 15, 20 years back. But let me tell you one thing. The answer to this is, what do I do after family medicine PG? I think you can do anything and everything a medical profession can do. I think most of the speakers have already brought out what all can you do once you pass out as a family medicine graduate. But probably I would bat for only two things. One definitely is the general practice. I think many speakers have already spoken about what are the advantages of getting into general practice. Dr. Gunjan, Dr. Jyotika, Dr. Gauri, they've all deliberated on that. But let me tell you one thing. It's the most fulfilling, and it gives such a great sense of gratification when you work as a family physician in the community. So if you are being trained in family medicine, I think your first choice should be to be serving the community. Okay. So general practice, I've in my experience, I am into practice only last 10 years. I don't know, many of you may not know, I was in armed forces for almost 22 years. I had a very good career there, very accomplishing career in the armed forces. But the most gratifying years of my professional life has been the last 10 years in general practice. So it gives such a sense of this thing. It gives you advantages like autonomy, flexibility, work-life balance, and the amount of the variety of cases you see, and most importantly, your long-term relationship with the patients. It allows you to make so many friends in your professional life. Most of your families, the patients will become your friends. So I think the first choice I vote for is to be in private practice. And it's not very difficult actually to set up your own practice. Probably we will have a session on how to set up your practice. It's all a misconception and misthought that you require a lot of investment to get into private practice, and it takes a lot of time to settle down in practice. But these are all the myths. We have seen many of our AFP members, including Dr. Raman Kumar, who is a role model as a general practitioner. Even my practice in last 10 years has seen is grown leaps and bounds. Actually, I am now planning to restrict my practice. So I'm only 10 years into practice. So you can imagine someone like Dr. Bansal, who's there, very senior practitioner. So there are a lot of misconceptions about general practice. I think we'll have another session on this. So this is one thing I would say should be the first choice. Of course, there are many options. you can, as a family medicine doctor, work as this is one question which everyone will say, "Ki, why we are not considered a specialist when you are practicing?" But if you are in general practice, you can work as specialist also. There are people who are working as lifestyle medicine specialists, diabetologists, like Dr. Gauri, the child development specialist, then palliative care specialist. So, I mean, you can do general practice, plus also you can restrict or focus on one area of your interest. GPs with special interest, we call it. So, general practice is definitely a career or a vocation which is very, very fulfilling. So, I would encourage all of you to get into general practice. There is a huge scope and there is a huge gap between the community level health setup and the corporate health, which is now even the smaller hospitals are gradually being eaten up by the corporate hospitals. So we want to have just the general practitioners and the tertiary care hospitals. The secondary care hospitals are fading away. So you have a big role to play in bridging this gap. So, and the other options would be to, because this is the need of our specialty now. A lot of new courses are being opened in medical colleges and DNB courses, MD. So there is a huge need for the faculty. So someone who is eligible for being faculty, I think you should choose to be a faculty. I think that is also a very, very gratifying and satisfying career. Of course, there are many other options which the other speakers have already deliberated upon. So, as Dr. Gauri rightly said, the sky is the limit for the family medicine doctor. So, don't ever think that what I'm going to do after my post graduation. So, is there any what is the scope for family medicine? Are we going to struggle in professional life? I am telling you, with my experience of 10 years outside my armed forces, I have not seen any family medicine doctor struggling for in the profession. The struggle is there, in fact, in other specialties, in super specialties, and you just come out and see people. You are all in in corporate hospitals. You are doing your training in hospital. So just go and speak to the specialist and super specialist. There is so much saturation there, and we are in a very critical juncture. The NMC is, every day they're coming up with different policies and all. So we will see probably quantum jump in the seats of specialties and super specialties, but there are no takers, because that is how, I mean, it is so super saturated and people are struggling to settle down there. Okay. So I won't take much time. I think there are many other leaders who would want to share their thoughts. So wish you all the best. And I'm very happy that this PG wing has taken a shape, and it's very, very active. I'm silently watching the interactions in the group, and it's really heartening to see how Spice Route is taking the PG's requirements to the desired levels. Thank you so much.
Thank you, sir, for sharing your experiences over the last 10 years of practice as a general practitioner. And next, I would like to hear a few words from Dr. Reshmi S. Kaimal. She is the head of the Department of Family Medicine at Luth Hospital, Cochin. Ma'am, I would like to hear a few words from you also, which will be helpful for all the residents who have joined.
Hi all, good evening. Am I audible?
Yes, ma'am.
Yeah. Happy National Family Medicine Day to all of us. So, I didn't expect to be called. So, I think I should not give a lecture, but I've heard this question many times in my department also coming up. So, what should we do, madam, after this? What is the ideal thing that we should do? The ideal thing for each person is different. And there are many options, I would say. I'll just compile all the options, and then you can choose what you want. Because from the beginning, when Dr. Serin said about government services, there is both the state government services where you can get through the PSC, or the national, the Union Public Service Commission, UPSC exams. You can be in central government services. Both of these have fixed salaries, the perks of a government job, as well as a stable pension. Most of these have, and fixed working hours. All these things are the advantages, but the disadvantage as of now is lack of a specialist cadre. But still, you will have the PG 11s in the, as far as Kerala government service is concerned. I know that we get a PG 11s, though the specialist cadre is not there. But what is most satisfying about government services that I have heard from many of my residents who have joined government services, that you get to practice what you have learned, because you have gone through all the areas and you know most of everything that comes to a primary health center or a family health center or a community health center. You get so much of work satisfaction and you can practice what you have learned. As of now, AFPA of different states, AFPA state branches have given memoranda to all the state health ministers, etc., for the specialist cadre. In Kerala, we have visited the health minister and the health secretary many times for the specialist cadre, and we hope that in the next 10 years, as you know, that AFPA has been formed only since 13 years, and so far we have made so much of improvement or in the condition of family medicine practitioners in India. So hopefully in another 5 or 10 years, all these things also will come into existence, that is a specialist cadre, etc. Now about private practice. In the private sector, there are different options. One is to start your own clinic, but as Dr. Gunjan said, you will need a financial balance for that. So, no time is, you should not wait till having a financial stability to start a private practice if you are inclined to that, because at every stage there will be challenges. So go for it. Start it. For that, like Gunjan suggested, you can have a fixed income on one side and then start a private practice side by side, and then fully engage into that. That is one option. Be it urban or rural areas, everywhere there is demand, and you need not have a tie-up with an MRI or a imaging, or a lab or something to start your clinic. You need a BP apparatus, a thermometer, or very minimum things. You are privileged that you are a family physician, that you don't need so much of investment to start a clinic. It's just your clinical skills and your communication skills that will help you more. So in that regard, you are at a much better position than the subspecialists or the other specialists. So that is one thing. Another thing is a polyclinic where you can be the primary physician and primary family physician, and others can join in. Other specialists can come and visit it, fixed timings, and or a group practice sort of, where it is a polyclinic setup. So that is also possible. And another thing is in private hospitals, secondary care hospitals. I know many in Kerala are placed as family physicians in secondary care hospitals and earning salary at par with the other specialists. In a corporate hospital or in a mission hospital like where I work, there is also a role for family physician. But please do not restrict yourself to health checkup alone. You should find other options also. You can do health checkup, and along with that, you should have some other outpatient load also. So another option is like where I work, an academic institution where you can have contact with academics. You can update yourself in academics. You can teach your residents, and that is also gratifying if you have that inclination towards academics and teaching. There are positions called for senior residency in PGI Chandigarh, where there is a separate department of community medicine and family medicine, but they are going to start it separately in family medicine in the coming years, and so they are looking for SRs in senior residents who have done family medicine. And sad to say, the last interview, there were not many takers for that. So there may be hurdles like it is far from my place, or I have to travel a lot, or I don't like that place. It is not my state, so how will I adjust to the language? There may be many hurdles, but opportunities don't come every hour. So when an opportunity comes, grab it and see if it is feasible for you, and if not, you can always leave it. But to stand outside and tell that this might not work for me is not the right thing. So that is another option. In academic institutions, many places they call for opportunities, but what we see in Kerala, I have seen that there are many options coming up in the WhatsApp group, social medias and all. But after all these advertisements come, again people ask, are there opportunities? So I think there are many other factors that pull us, maybe the finance, maybe the family, all other things. So, but when you decide that you have to have a career, I think you should let go of some of your fears and some of your inhibitions. You can have other interests like the GP with special interest in UK, like you can do in palliative care, geriatrics. I myself have done in palliative care and geriatrics. You can do in diabetology, infectious diseases, tropical medicine. So many options are the mental health. So everything adds on to your expertise in a specific area. You are primarily a family medicine specialist with an interest in a specified area. It's not like subspecialization where you'll be restricted to that area. You can have your general patient load, and this will be an additional extra patients for you. So that is one option. I think I've covered all these. If I've left out anything, I am happy to take questions at the end to how to start all these things. And there are options abroad also. I think someone will be talking about that also. There are options abroad, mainly in the Middle East, where you can go with your degree here. Your MD or DNB degree, you can practice in the Middle East with certain years of experience. If you're planning to go to UK, you'll have to write the exam there. If you're planning to go to US, the exam there. But in Middle East, definitely with your degree, you can practice. So happy to take questions at the end. Over to you, Vishnu.
Thank you, madam. I think you have made my job very easy, that you have consolidated what all the speakers have mentioned so far and into a capsule format in a very easily understandable format. I think the residents should have got a clear-cut idea on what she have told. And having discussed about the various opportunities that we are having in India, I would just like to throw some light on what are the opportunities we as family medicine specialists have in abroad, in the foreign countries. So what are the requirements for that, and how well we are accepted in foreign countries? To give a clear idea on these aspects, I would like to call upon Dr. Shehzad MU. Dr. Shehzad is a DNB Family Medicine, MRCGP International, and MBA in Hospital Administration. And he's also the past secretary and current advisory member of AFPI Kerala State Chapter. And currently he's working as a specialist family medicine in Aster Clinic Al Nada, Sharjah, UAE. Over to Dr. Shehzad.
Hi, good evening. Thank you, Vishnu.
Welcome, Dr. Shehzad.
First of all, I'm very glad to meet all of you. Actually, I've been out of the country for the past 6 months, and it's a very happy moment to see some of the faces here on this very special day of the National Family Medicine Day. First of all, let me wish all of you a very happy National Family Medicine Day. Right. Vishnu, can you just make me the host so that I can have a short presentation so that I can just put it on? Is it possible?
Dr. Jyotika, can you just make Dr. Shehzad the host, co-host?
Yeah, he's already co-host, and even screen sharing options are there. He can, Dr. Shehzad, you can go ahead and do a screen.
Shehzad, please try again. I have enabled.
All right. Is it visible now?
It's coming.
It's visible.
It's visible.
All right. So I think my voice is clear. Someone has put it, my voice is echoing. Is it?
It's better now.
Slightly, yes.
Okay, I'll try to make it more clear. Anyway, I'll just, as Vishnu had said, it's about the abroad prospects. I'm just going through the Middle East prospects because I'm right now here. And that is one area which I have actually explored kind of before kind of getting here. So it's just a brief outline, just for 3-4 slides to present before you. Basically, let me say how I came here. After my DNB, I had actually worked with the government there, like the Kerala state government, for the past 6 years. So basically, it was a resource for setting, but then, of course, resource for setting is a very favorable setting for family medicine practitioners like us, because there's a lot to do. So after 6 years, I thought of changing the exploring much more, because like we say, it's always greener on the other side. So I thought of why not explore it. So that is how I basically came here. So why Middle East? I'll just quickly go through this. Why Middle East? As everyone has in their minds, the first thing that comes into our mind is an attractive pay scale compared to what we have in India, and a good work-life balance, as many of the people have said here, and I'm right now experiencing that from my comparing my work back in India. So here, most of the doctors have a fixed work schedule. Like most of the specialties, it's like 8 hours in a day, 6 hours, 6 days in a week. So 48 hours is the fixed rule, and beyond those 48 hours, you have your time. So there's a high, very good work-life balance here, which can be attained. And of course, high living standards and good education systems, which actually you get exposed to a lot of education systems here internationally, not just the Indian syllabuses, but there are other options as well. And of course, a global exposure depending on the place where you plan to relocate. So specifically coming to family medicine in GCC, the first and foremost thing I was very happy about being here is the family medicine is a recognized specialty here. Especially the government has been coming up with many favorable policies which has actually increased the demand for family medicine specialists. So that is a very good sign. But again, like back in India, the everything under the medical specialties is being more saturated here. The general practice, any specialty, it is being increasingly saturated here. So there is of course competition, and depends on how hard we try and how competent we are. And the other thing is we have well-defined scopes of practice here for each specialty that we intend to practice. Like in family medicine, I think we've talked about many subspecialties or many sub areas which we can actually focus on. So depending on our interest, there is a lot of option and there is a lot of potential for practicing in a very well-defined area of practice, so that you get seeing patients more and more of those scopes particularly. The practice culture here, the first thing which comes into my mind, which I found very different back from home, is we tend to see a multicultural, multilingual community, wherein anywhere you go in the Middle East, you have people from all around the world. So that is a huge difference that when you practice compared to when you practice back in India. And I was skeptical basically because I was actually born and brought up here. So listening to the healthcare system here, I was very skeptical with the amount of cases that I would be seeing and I would get exposed. But to my surprise, we have a lot of wide exposure to many different kinds of cases. Like for example, in the clinic where I practice, it's a pretty good residential area, and we get cases that can actually, you can imagine, that can come into a primary care practice, ranging from a small fever to anything like a cancer or an MI. We get patients who come with MIs at least every week. We get at least 1 or 2 cases here. So it is that frequent, and there is a lot of potential to see wide exposure of cases, many different cases that I haven't even seen back in India. Again, like I said, it's mainly because we have a lot of people coming around from all over. Again, from the perspective of being a family physician, the work nature depends on how you actually intend to practice. So there are independent clinics, small clinics here. People even set up their own clinics after few years of experience learning the setup here. So some of those clinics might be single-handedly run. So you might be the sole practitioner there. Again, there are polyclinics where you practice as a group practice, wherein you practice with many other allied specialists. And there are corporate clinics which have the same manner of practice. And hospital-based practice is also there, where you have a family medicine department separately, which exclusively deals with the patients who are directed to family medicine department. And more so, there are family medicine specialists who actually work attached to the emergency medicine department, like a fast track OPD system. So that's again something that we find back in India. So these are the common work natures that we find to practice here in the Middle East. The Middle East, as I say, most of the countries in the Middle East have these kind of practices, especially for family medicine. And one thing I would say is a big difference back from India is here in the Middle East is mainly, especially in the UAE, the healthcare system is mainly backed by insurance. So many cities, many emirates here are mandatorily giving insurance backup for the residents here. So insurance is a mandate for most of the residents here. That means that healthcare system is basically almost 60 to 70% at least, or more than that, is based on insurance. So that is something that we have to catch up from here. Again, there are people who don't have insurance, and the practice becomes much more difficult in dealing with patients who don't have an insurance, because the expenses are way higher here. So that is one reason we find people coming back to India for further expensive treatments and further management of complicated cases. Just summing up the pathways and requirements to different Middle East. Most of you must be knowing this, but just to summarize, I've just put in some countries here and the exams and the minimum experience needed for entering each of these countries. So basically, it's like 3 years of experience post specialization you need for most of the countries, except for Saudi Arabia, which actually needs just 2 years. And in UAE, you have 3 different exams. You have an exam for DOH, which is Department of Health for the Emirate of Abu Dhabi. You have a Department of Dubai Health Authority, that is the DHA, specifically for Dubai, and Ministry of Health for other Emirates, which includes the other 5 Emirates. So these 3 are separate exams for these separate cities. Of course, if you do one, you are able to transfer it to the other emirate as well after a few months. That is also possible, but this is how it is. So considering the difficulty, if you're planning to attend the exam there, of course, the DHA is the most difficult exam that you will find out of a lot. After which DHA and MOH exams are kind of similar, a little bit easier than the DOH, because the pass percentage is a bit lower. So again, in the UAE, I would say the cost of living is high. You get paid well, but then the cost of living is also high. There are places where you can have a lesser cost of living also. Qatar, you have the QCHP exam. You need 3 years of experience there. Bahrain, you have the NRHA exam. You need 3 years of experience. Kuwait, again, the MOH, 3 years. Saudi, you have a Saudi medical licensing exam, 2 years. And Oman, you have a theory and a viva to pass. If you're planning to go to Oman, again, 3 years of experience is needed. Compared to the other countries in Saudi and Oman, the cost of living is a bit lower. So this is just a sum up of the countries here, right? I think that's it. To make it very brief, and just what I had actually experienced, setting up priorities help you make clearer and easier decisions. So if you're actually planning to move abroad, if that is according to your priority, it's a very good option. But again, it's according to personal preferences, because if your personally, I feel that if you're able to put up your own clinic back in India, that would be the best option, I would say. But this is also a good option in many ways, like I discussed before. Right? Thank you. If you have any questions or anything you just want to clear, I'm really glad to help. Thank you. Over to
Thank you,
Vishnu.
Thank you, Dr. Shehzad. And I think you all might have got an overview about the different mode of practice. And now we'll have a question answer session. And if you have any questions, you can put it up in the chat box. And first question I've received is to Dr. Shehzad, what is the pay scale in UAE?
Pay scale in UAE and in many other countries, you get paid in equivalent to at least 5 lakhs plus in most of the countries. Again, when you go to low cost of living countries, the pay scale can go a little bit down. But then again, in UAE, Qatar, Kuwait, and yeah, most of these countries, they have a similar pay scale. Yeah, I saw one more question up, Vishnu.
Yeah. Yes. Yeah. Do we have any upper hand in having an MRCGP international degree? Is the question.
Yes, we
Can you address
definitely
that?
have an upper hand here, not because it's part of the qualifying criteria as per in paper, but then most of the recruiters here and the hospitals here, they somehow are more interested in those who have a UK degree, for that matter. So MRCGP International is an international degree. Of course, it's not directly from UK, but then it still has value. Even if you have a DNB and if you have an MRCGP International on top of it, you tend to have an edge over the people who don't have.
So one more question to you itself. How will you move on for taking an MRCGP, or how to approach for MRCGP? Please guide.
Of course, MRCGP. What I understood is that it's something that you need to practice in your day-to-day practice. And the MRCGP OSCE is basically what you are actually able to do in your day-to-day practice. So that's nothing to be learned in 1 or 2 months. It takes some time. And of course, there are, regarding the theory, the AKT for MRCGP, there are 2 steps, as you know. For the AKT, I personally referred the Oxford Handbook for all the guidelines, the NICE guidelines that really helped me. And like for the OSCE, which I said, there are specific cases that you can get a lot of references online. And even after that, you have to practice them in your day-to-day practice, which I was actually being taught by my mentors, which I even tried. And that really helped me in passing the OSCE quite easier.
Thank you, Dr. Shehzad. Now we have one question. Why some central institute like AIIMS family medicine is combined with non-clinical branches like community medicine? I would request Dr. Zarin, can you take up this question?
Vishnu, can you please repeat the question?
Why central institutes like AIIMS have combined family medicine with community medicine? So that is a question. Because of this, even some medicos consider family medicine as PS. That is the question.
To be honest, I don't have an answer for this. Why they have combined, I don't know. Why they have nothing in common, and maybe they think that since this is a developing specialty for faculty management and all those things, they might have combined. I don't know why. I don't have an answer for that.
I think I also understand where to fit in family medicine remains a question
Yeah,
to them.
and one thing is clear, means we don't have faculty, and even for private, when we say that we are seeking for specialist jobs like after family medicine, even the private qualified family practitioners. So maybe because of that scenario, they have means it has to be put into some place. So um, they might
I
have
think
thought like that, I guess so.
I hope gradually things will change, get
Yeah.
separated as more and more people comes in. That is what we expect. Thank you, Dr. Seren. And I would like to pose a question to Dr. Gunjan. In the era of super specialty and a family medicine doctor, how can we project ourselves in a GP and develop a patient base? Dr. Gunjan.
See, technically, we feel that we are at a back foot when we have a lot of super specialists around us. But when you reach the ground level, you understand that patients are very miserable when they have to find out who they need to meet. And most of the super specialists are charging a lot of consultation fees. Of course, they think they have studied so much, so they deserve this. And there, when your availability, the time you give, and the guidance you give becomes so special that gradually you will see at the ground level patients prefer a GP. And you have to understand in Indian scenario, the availability of doctors, of quacks in periphery, the alternative medicine is having a huge market just because of this. The availability of doctor is a big problem. So just don't be scared about the availability of super specialists, because at the end of the day, patient wants to know what treatment is best for him. And the level of confusion in corporate hospitals, the patient is running from this department to that department, they have no idea what problem they have. So that will never be a problem for you. When you start your practice, you'll understand how important your department is. Personally, I am handling vaccination, the young 6 months, 8 months kids, they have some disease, they're also coming here. Female patients are coming here. Unless there is some surgery involved, they all prefer a clinic or setup where physician is handling it. And a family doctor is so important. They trust your decision more than a new doctor they visit. You will understand this only when you start practice.
Thank you,
Yes,
Dr.
to
Gunjan.
add,
I hope.
Dr. Vishnu, one more thing. So our special, can I? Yeah, thank you.
Yeah.
So our specialty is blessed with the, the capacity to separate signals from the background noise. Please trust your instincts. You yourself can see that as we specialize, we have a tendency to forget, our basic knowledge. And we are not like focused on any age specific or disease specific or organ specific. We family physicians are trained to see people or patients as a whole, and we have that broad knowledge, and we have enough academic background and training to treat almost everything. And please trust your instinct and never doubt yourself. You can actually delve into the minds of the public or the community in which you are practicing, and thereby you can develop a good patient backup. You need not worry. Thank you.
Thank you, Dr. Namita. And I think next question I would pose to Rashmi ma'am. Ma'am, still there is a misconception about family medicine. It's not a specialty, but just an upgradation of MBBS. Still, some people have that thought. What is your kindly throw some light on this fact or this aspect?
So it is up to you all all the residents who have taken up family medicine to, to prove that misconception wrong. Okay. You have done a specialty. You call yourself a specialist. You call yourself a family medicine specialist. I have seen some people are even hesitant to put it up in their letterhead or something as family medicine specialist. First, you should be confident that you are a specialist, and then you can talk to others. I think the first thing would be like, if somebody asks you, what did you specialize in? What would be your basic instinct? You would say, why to explain about family medicine? You will say that I'm a physician. There starts the issues. If you say that I've done family medicine, I'm a family medicine specialist, people will ask you what it is. And then you can explain to them that this is something that existed long back when the MBBS graduates were equipped to train to practice primary care in a very, trained way, qualified way. But now we all know the MBBS students are not being trained in that way. So have to have adequate skills to practice primary care, you need an extra 3 years of residency. Somebody asked in the last Hyderabad conference, why do you need 3 years more to practice primary care? So I wanted to answer then, but did not create a confusion there. But the answer is that how many months of OBG posting do you do in your MBBS? You do 3 plus 3, 6 months, and maybe 3 months more in your internship. But still, if you want to conduct a labor in this era, you need to have 3 years of PG in OBG. Okay. So now, how many months of primary care training have you gone through in your MBBS? You have not gone through. You have just gone through your field visit and PHC visit during your community medicine posting, and even in internship, maybe 1 or 2 months. So, what needs extra training? OBG or family medicine, primary care? So that is where you should explain to people that this is not equivalent to MBBS. This is not a glorified internship, because in internship, what you do is you are basically working at the spinal level. Most of us are working at the spinal level. What the consultants say, what the PGs say, you just parrot and do unskilled labor. But when it comes to PG, you are taught in family medicine, you are taught to think logically, examine a patient properly, take history properly, you are trained in communication skills. Now, people might ask, what if we don't have a proper family medicine department where we are not trained in that way? We are just going through internal medicine and it is almost like MBBS. I would say that the moment you take up family medicine by choice or chance, you have to read up several articles on family medicine, books on family medicine, and create that approach within you, even though the hospital or the institution where you learn may not be promoting that. You can parallelly during your course, you can understand more about family medicine. When we all did our training, we were under the internal medicine department, but still during the training, we all learned what family medicine is, how it can be put into practice. You get knowledge from different specialities when you go for your rotational postings, but basically you read about family medicine and how that approach is different and try to put that into practice when you see each patient. And even if your institution does not train you properly as you think in family medicine, when you pass, you can practice proper family medicine. So you have to explain to people that this is not equivalent to an internship. That concept will change only slowly. It has changed so much in the last 15 to 20 years, and it is definitely going to change further, but you should have the patience. It is not a bed of roses like other specialities. One of our family medicine specialists from Kerala once said, a patient came and asked him what is family medicine. So he asked the patient, do you know what cardiology is? The patient said, yes, that is that. How do you know it? Because I know. Okay, so you go and just read what family medicine is. Then you will also understand what family medicine is. I'm not saying that you should speak so rudely to the patient, but still, you should explain to the patient that what family medicine is, how family medicine is different from MBBS or internship. For that, first of all, you should have an idea. If so, you will not have that. You will have that. You can explain to others also. Like the previous question, also I wanted to answer why the Department of Family Medicine is clubbed with family medicine. Can I tell 1 or 2 points about that, Vishnu?
Yes, ma'am. Yes, ma'am.
Yeah, because even in private institutions where DNB is running, where there are no specific family medicine departments or no specific family medicine faculty, we have they have, I mean, National Board has told that it can be under the internal medicine department or the pediatrics department until a family medicine faculty is there. So similarly, in government setup, now that it has started only I mean, in the central institutes, it has started only recently. So they wanted to club with some department who can take care of the residents. And ideally, they thought that public health would be the best option to combine rather than a hospitalist medicine like an internal medicine. That is why they have combined with community medicine. And most AIIMS and PGI are planning to segregate family medicine from this department in the coming few years. So hopefully in the next few years, we'll see that this department breaks up from community medicine and a separate department is set. Now, I hope it is clear.
Thank you, ma'am, for clarifying this question. And next, I would like to invite is the President AFPI National to speak us few words and as well as answer the query. Sir, many of the diploma family medicine students have a query of secondary DNB options. I understand currently we don't have secondary DNB options yet since the diploma family medicine was started recently 1.5 years back. So I think Raman sir will be the right person to speak on this. Raman sir, can you please address the gathering and answer to this query? Raman sir, it's not able to unmute Dr. Jyotika.
Yeah, one second. Confirmed. Yeah.
Excellent.
I think, sir, you can speak now. You're on mute.
1 second, sir. So you can start your video. That's not restricted.
I think you can make him the co-host. And
Yeah, that's what I'm doing. So please try now. So you're on mute.
Hello.
Yes, yes, we can hear you.
yes, sir.
Yeah.
Yes, sir. Yes.
Okay, so thank you. Asked me about the secondary DNB positions, which actually the DNB family medicine was not there earlier. There were diplomas of other specialties, pediatrics, gynae, ENT, and all. So there was already a provision for secondary DNB because there was a demand for that. And only recently, when the new diplomas were created by the National Board, DNB family medicine was added. This was never before. So naturally, there was no thinking earlier about the secondary DNB seats. But now probably, since there is demand and by the candidates themselves, because everybody wants a full qualification in all respect. So hopefully there'll be seats also, and there is a process ongoing. And for that, for secondary DNB seats also, there will be an accreditation process of the institution. So once the institutions are recognized for taking secondary DNB seats, they will be announced. But this may take some time for now.
Thank you, sir. I would also like to invite Dr. Vandana ma'am to speak a few words. She is a National Secretary of AFPI.
Good evening. Vishnu, this has been a wonderful session and quite an eye-opener for residents. Just a sec. I've been going through the queries and questions by the residents. So, what message I want to give them is to trust their own specialty first. There are so many questions regarding no department, no jobs, nothing. So, unless until you trust your own department and specialty, you will not be able to create spaces. It is only demand and supply. So, there are so many people who have been doing DNB family medicine or family medicine diplomas and looking jobs in different specialities. They want to do critical care, they want to do medicine specialty, they want to do gynae practices. So our specialty open arenas and horizons to every specialty, but it is best to stick to our own specialty. As somebody has just put a question there that in Delhi NCR you get only job in ICUs or as per the residence level. So I agree. There are no jobs as such open for family medicine. You will not see the family medicine specialty written over there. But I have seen people working in every specialty. They've gone and they have been welcomed and accepted well. But it will take some time to create a department, to create the specialty jobs and SRship faculty and everything, which is under process. Till then, you stick to your specialty, try practicing. We are best for going to the communities and doing the practice there. So when you join the specialty, you should always keep thinking of practicing in the community, which is the best thing. And as far as job in Delhi NCR is concerned, preventive health checkups are there. Then SRship many times you get in government specialty hospitals on the basis of your 2 years practice, 2 years experience. If you want and demand the job as per your specialty and your degree, you will not get it. So what I mean to say is that people are doing wonderful in the communities. They are earning very well. They are settled well. I'm working in a super specialty hospital, which is one of the India's best hospital. And trust me, if I admit a patient, I'm not sticking to one age group. Even 12 years of patient is admitted who is a pediatric age group, nobody questions me because everybody knows I'm a family medicine person. I'm entitled to see that patient. So even if somebody is saying that MBS people are exposed to elderly care, fall, elderly urinary problems, no. You are trained specially for them. So stick to your specialty is the message I want to give all the residents. It is a wonderful thing.
Thank you, ma'am. Before we wind up, I just want to have few words from Srinivas sir also. He is a practicing family physician from Telangana, and he's in charge of Srinivas sir.
Am I audible?
Yes, sir.
Yes, I am following only from the half of the session. I was not totally aware of the session, and the session is very needed, very much needed, and all the inputs are very fine. First of all, we should be optimistic. In the next few years, definitely, we have a good future. Really, our future is bright. Because the present burning issue is greatly debated issue. Why the PG seats are became vacant? Almost 13 to 14,000 seats are vacant now. Even after reducing the percentile, also there is no guarantee that all the seats will be filled up. So this problem, when the alternate PG seats are 67,000, but the government is planning to increase the PG seats to 1 lakh. That is the target of the central government. So how can they increase to 1 lakh? And how can avoid this problem of seats becoming vacant? The only solution is at least they have to give 20,000 seats for the PG, MD family medicine or DNB family medicine. That is the only solution. That is the need of the hour. That only will satisfy the people's health and well-being needs. This will be one or the other day soon. It will be appreciated, and it has to be accepted by the authorities and policymakers. So let us be optimistic. And first of all, the next thing is, are we really can be defined as family physicians? Most of the institutes I have seen, real family medicine training is not being given. Like our competencies are not up to the mark. Our skills and knowledge is not up to the mark. So we have to build those skills. We have to build those knowledge. We have to build those competencies. Just to see individual who are doing private practice, just review their activity. What are the cases they are dealing? Are you dealing with only fever, hypertension, diabetes, and some other issues? Few other issues? Are you seeing a child? Are you giving vaccination to the child? Are you doing the normal deliveries? Are you treating the febrile seizures? Are you treating menorrhagia or menstrual problems or elderly issues? So ours is primary care specialty is promotive, preventive, treatment, rehabilitative, and palliative. These also all aspects should be dealt with, and all the diseases, common disorders affecting all the age groups, both male and female, and all the organ systems should be dealt with. How many of us are competent, and how many of us are actually doing this practice in our daily life? This we have to review it. So first of all, my appeal to the recently passed out candidates to develop the skills, develop their knowledge and competencies, be a real family physician. Then that will definitely give a lot of scope for us. And all of our doctors, Mohan and Reshmi, Vandana, they all have clearly stated that building your own practice is in this present scenario, when the opportunities are not huge, many opportunities are not there, because there are no government jobs. There is no departments. There is no MD family medicine. In such a unfavorable situation, the only alternative is we have to build our own outpatient clinic. At least build your OP, at least 30 patients in a day. If you reach that level, that will be great. That will be a success. It all depends upon whether you can afford to start a good clinic or polyclinic with some lab and pharmacy facilities. That all depends upon your financial situation. If you are able to do that, you can succeed. Because one doctor, Dr. Vikram, recently passed out 5 years ago. He started his own clinic in a IT corridor, and he is doing very well. Not only that, he started another similar clinic in the IT corridor, IT area also. There also he is doing very well. He is very much satisfied. And the professional, not only professional satisfaction, but the earnings, especially the earnings also, more than what he expected. So there is a lot of scope is there. The only thing is whether your skills are enough, and whether your competencies and knowledge are enough, whether you have that passion to practice real family practice. That is the crux of the question. In this unfavorable situation, try to build your own OP, outpatient clinic, at least daily 30 patients. That is, I think, that will be a good achievement. Suppose, due to various reasons, if you are unable to concentrate on outpatient clinics, you work wherever you are interested, either in the cardiology department or in ICU or in emergency, in any setting. But at least my appeal is at least have a 2 to 3 hours your own outpatient practice. Learn to examine the patient, take the history, treat the patient. That is very important with the concept of the family medicine. as a genuine family physician, treating all the common disorders, because 70% of the disease can be treated by the family physician in the outpatient setting only. This we should stress again and again. So at least 2 to 3 hours, you try to see the patients. If you cultivate that, I think you will have a greater professional satisfaction. And ultimately, I would like to stress that the skills are important. Your personal interest is important. If you alone have interest and you don't have skills, you will not shine. If you have skills but you don't have an interest, also you will not shine. So you have to try to develop the interest, passion, and the corresponding skills. Then definitely it is a very, very good profession, and it will give a lot of satisfaction. You can see 50 to 60 patients daily. You can treat them. A lot of respect and response from the families and the patients' families. This I would like to stress. This is, in brief, my opinion is concentrate on the OPs. You build your own OP, and all the things that I have told you. Thank you for giving me the opportunity, Dr. Jyotika and Vishnu. Thank you.
Thank you,
sir.
Thank you, sir. For want of time, we are just concluding the session. Any other queries, you can put it up in the group. We will answer. I think family medicine as a specialty have grown over the years, and it's way forward. We will have good times coming up for the specialty. And I'd like to thank all the speakers and panelists who have shared their experiences, and all the senior members who have contributed their ideas and opinions. And thanks to all the participants for joining in this meeting. Thank you, one and all.
Vishnu, just one last question, I think. In CHC and district hospital, diploma family medicine is considered as a specialist class 1 or only like MBBS class 2? Somebody who's been in the government sector, either Dr. Serin can answer, or Reshmi ma'am, if you can answer.
Can I answer it?
Yes.
Yeah.
Ma'am, your voice is breaking.
They are considered as specialists only. If they have a postgraduate degree, whatever postgraduate degree in that specialty, they are considered as specialists in that area. As of now, family medicine doesn't have a specialty cadre, so only when that comes up, automatically this diploma family medicine people also getting the same cadre will come up. I hope that answers it. There is no MBBS class 2 or specialist class 2. There is an MBBS, there is specialist. That's all.
Specialist. Okay, ma'am. Okay, thank you. Okay, let's wrap up. And any other queries can be put up on the group. And this recording will also be available on our YouTube channel soon. Thank you, everyone, and good night.
Good night.